A very warm welcome to everyone joining us on the pilot episode of the She Belongs podcast. I'm Varshini, your host for today, and we have an incredibly exciting guest joining us on this episode. She's an associate professor of obstetrics, gynecology, and reproductive biology at Harvard Medical School, a fellow of the American College of Surgeons, and a practicing surgeon in gynecologic oncology at Massachusetts General Hospital. Her long list of accolades can be an entire conversation in itself, but the best part about her work is the sharp focus on the harshest problems surrounding women. One of her specializations includes reproductive care in the backdrop of disasters, which is closely related to the topic for today, gender-based violence in disaster settings. As part of the Gender-Based Violence Project affiliated with the Coronavirus Visualization team, we're absolutely thrilled to have Dr. Annekathryn Goodman as our guest today. A quick disclaimer, the topic we will be discussing is understandably sensitive and could be triggering for certain sections of the audience. The aim is to shed light on these issues by kickstarting this difficult yet important conversation. So without any further ado, let's get started with our conversation. Hello, Dr. Goodman, and thank you so much for joining us today. To kick things off, I will ask you an open-ended question. Could you tell us more about what you think makes women in a disaster setting more vulnerable to violence?
Thank you for that question. I think before answering it, maybe we should do some definitions because there's different kinds of violence. So there's violence that you think about where people are harmed by a weapon or something like that. You're talking about violence specifically targeted to women. That's usually what's called gender-based violence. And gender-based violence can be physical, it can be psychological, it can be a deprivation of rights, such as the inability to have food. It can be a deprivation of the inability to go and seek medical care because you don't have control over those decisions. It's really considered very much a human rights abuse, specifically targeted in a gendered way, so that women would be more targeted. And then there's a form of gender-based violence that has to do with the relationships that women have, and that's called intimate partner violence, related to the partner, the husband, the boyfriend, the sort of romantic partner that is part of a woman's life. Intimate partner violence does also occur to men. It's important to acknowledge that. It's much more frequent for women. And the statistics are that 1 in 3 women experiences some form of intimate partner violence or gender-based violence. So it's extremely common worldwide. So just unrelated to a disaster, women can be vulnerable to intimate partner violence, and it is the leading cause of violent death for women. So that's sort of a baseline. In a disaster, many things happen, and it'll probably be related to the particular culture, norms, environment of the location of the disaster. So it would be hard to have a blanket statement for what happened, say, after Katrina, the huge disaster that destroyed New Orleans and Louisiana and many parts of the Gulf Coast. There was an uptick in intimate partner violence after that. Maybe the reasons for that might be slightly different than the tremendous gang rape and sexual assaults that occurred for women after the Indonesian tsunami in Sri Lanka, that are well documented, what happened to women after that. So they may be different. But I think as a general thought, it has to do with vulnerability, lack of resources in the environment, and lack of protection. So, and perhaps maybe the other one would be the traditional roles that a woman may have that lead her to not be able to protect herself. That is, she has children that she has to manage, she can't run, she can't abandon them to protect herself. She may be responsible for getting food for the family, getting firewood for the family. Another example would be what's happened, say, in the sort of Darfur genocide by the Sudanese government, where women from the villages in Darfur were displaced, and then they would be raped. It was sort of massive rapes when they went to get firewood. And so again, the sort of limited resources, the inability to protect themselves, and the need to continue to perform their domestic duties. So there's lots of potential reasons why there's an uptick. It may also, of course, have to do with what's happening with the perpetrators of this violence, their frustration, their sense of loss, how they've been raised to express loss and fear and so forth. So it's not just there's this kind of massive faceless, rapist out there. It's just there's something going on that has led to an increase in behavior that's normative and potentially accepted in society. Maybe I'll stop there to see if there's any clarifying questions to that.
I completely agree, and I really liked how you explained what could be triggering the actions of these perpetrators. We often do think of them as faceless monsters. So, my next couple of questions dig deeper into the perspective of a first responder in these disaster settings. So, how is the experience as a first responder different in the backdrop of a disaster as opposed to a hospital environment like Mass General Hospital?
So it's a great point. And parenthetically, as I think about your question, it leads me to reflect on how one needs to train and lead in these different settings because they're quite different. So Mass General Hospital and any large hospital medical environment is a place that has multiple resources. It's got many different specialties, many different instrumentations and medications and resources that are available. So whenever you're taking care of a patient, say even someone with a car accident, so a trauma, you have at your command people like trauma surgeons, you have a blood bank with blood products, you have a pharmacy with antibiotics, you have an operating room with amazing anesthesiologists, you've got IV technology. So you have like lots of different things. So that's the one thing. And the other thing you have is you have what's called a standard of care. You have policies that are based on data-driven medicine about what is our standard of care of how to treat somebody for this and that. And in general, we have the support to allow the best standard of care possible. In a disaster, depending on the particular location of the disaster, it may range from an environment that has that infrastructure, but then on top of it just lost all the power. Say for instance, Superstorm Sandy, which was a catastrophic storm that affected the east coast of the United States and caused power outages. It caused massive displacement of people. It caused evacuations from hospitals. There were many disabled people who had to be moved. Their kidney dialysis program had to be moved. Lots and lots of examples. It was quite an extraordinary, and it's been, gosh, I think close to 10 years, and there's still people recovering from it. So but still, it was in an environment with lots of good infrastructure where you could recruit and bring people in to take care of it. There's other disasters, like say, let's take Haiti after the earthquake, where the infrastructure was completely destroyed. There were no existing hospitals standing. The government was destroyed. Parliament was destroyed. Many of the leadership of Haiti had been killed. And so the United Nations came in to try to run and police the area. And it was quite a lot of chaos. In that environment, you have very, very few resources and very little infrastructure. one of the my most profound lessons came from actually a chaplain from another disaster team who said to me, in a disaster setting, there are, well, in general, there's daytime rules that would be standard of care, lots of resources, great infrastructure. And then there's nighttime rules, which is you don't have very much and you just do the best you can with what you've got. And it's not necessarily the standard of care. And I think in many disasters, you're working on nighttime rules, which is very stressful because you know that if you were at Mass General, this baby could be saved, this woman could be saved, and so forth. But you're in an environment where they die because it's nighttime rules. You don't have the equipment to take care of them.
That is so profoundly heartbreaking, and I can feel goosebumps just listening to you talk about nighttime rules. I will follow that up with two related questions, the first more broader than the other. How do first responders navigate the emotional stress and trauma that comes with witnessing a disaster setting? For example, I remember reading about a first responder committing suicide in New York due to the trauma she endured when dealing with COVID-19 patients. And secondly, on a similar note, your research touches upon providing treatment to three pregnant women in Haiti who suffered from paraplegia, quadriplegia, and fatal heart failure. So, how do you personally navigate the devastating aftermath of disasters?
I think there's a certain uh, gene for disaster response. There's a certain gene for being a firefighter. Uh, People who, everyone else is running away from the fire, and then there's some people who run towards the fire. There's been studied actually psychologically, is that people who do that have sort of a high level of self-criticism. They have a perhaps generated from their lives and their own experience, a need to try and save other people, perhaps because maybe they grew up and their mother died of cancer, or something happened, but there's some drive that's led them to this place where they run towards the fire, either figuratively, metaphorically, or really truly, like the firefighters in 9/11 who ran into the buildings, and many of them were killed. So that personality is very hard on itself. And so there was there's many examples of responders who will commit suicide, and they usually do it because they have a deep sense of personal failure. So that's a very dangerous part. That's sort of the flip side of the heroism, is also this fragility, this vulnerability to failure, to feeling like it was your fault if you couldn't save someone. And so I think in training, and then in sort of developing, let's say, infrastructure around disaster responders, I think this is really much more done today than it was, say, even 20 years ago, is having counseling services and so forth. You had in your written questions asked about a recent tragic case of the New York emergency room doctor who killed herself. And I'm very, very, very profoundly moved by her story and many other stories like it. And I think, I don't know her at all, but I think that she reached a point of her grief could not be managed. Her grief at seeing what she saw. I mean, what they saw in New York City during the surge in March was just unspeakable. Dead bodies in the emergency room, and I mean, just like horrible, macabre sort of stuff. And she basically couldn't get her head around that. And then her own sense of personal shame and failure, was more than she could manage. It was very, very, very sad. For myself, which was also your question, my personal journey is actually, well, I also have that gene, I'll admit it, I have that vulnerability too, is that I've been able to navigate it so far by focusing on training. I would say I'm an overachiever and I'm overtrained. And I'll give you an example of that. My first disaster deployment was in 2003, 2004 to Iran, after the BAM earthquake of 2003, which was a catastrophic event in Iran. It was a very profound and privileged experience to go into there. I think there was, I don't know, 60,000 people died. I mean, it was another situation where the complete infrastructure of a small and completely modern city was destroyed. And all the healthcare providers of that city were killed. And so they really required a lot of external help. But it was very, very hard. And when we came back, actually, two of my colleagues killed themselves. So yeah, not right away, but over the next year. And I've thought about that a lot. And I actually decided I needed more training in how to manage grief. And so that was the beginning of my journey to becoming a chaplain. So I took a lot of chaplaincy training, and then I did a theology degree and became a chaplain. And my whole goal was to figure out how to manage grief, because I saw people die of grief, and I saw my colleagues not be able to manage their grief. So for me, I respond to that by trying to be better, and to try and get my skill set up so I can manage it.
Absolutely. Thank you for sharing such personal details about your journey. It just completely broke my heart when you talked about losing your colleagues to suicide. I also think you touched upon a very crucial point, the training needed to manage grief. I think grief is such a uniquely human emotion, but also has the power of being so destructive. So, thank you for telling us about that. Moving towards a topic that is very relevant to everyone in these troubled times, the rise in gender based violence during COVID 19. So, would you classify COVID 19 as a disaster setting? And if yes, how do you relate this experience with the one you had in Haiti? And if not, what are some differences?
Great question. I've thought a lot about that. The difference is, in some ironic way, the world is it's easier for the world to manage something like Haiti than it is for them to manage COVID. And I wonder why. You saw this tremendous outpouring of generosity and funds and volunteering to go and help after Haiti, after many, many, many of these catastrophes. You name a catastrophe and people are running in to help and sending toys for children and food and this and that and the other, blankets. So it's almost like you can get your head around this very discrete, finite moment of crush, loss, destruction, and then you rebuild, right? The thing about COVID is that it's almost like, the story, this is a little bit, well, anyway, the concept of you put a frog in a pot of water and you very, very slowly heat it, and the frog doesn't realize that its life is in danger until it's too late, until the water is boiling. I feel like COVID is like we are frogs in the water. And that when it started, it was like, oh, that's just, in China, right? And then it was like, oh, that's just on the cruise ship, but that's not going to affect us, right? And then et cetera, et cetera. We all know now here we are into it, close to a year now, right? We're getting close to a year anniversary, and we can look back with some perspective on the fact that this disaster, which in the United States has now killed 250,000 people. I mean, that is more people than most of the wars we've been in, right? And I don't know, in India as well, I don't know how many people have died. I know so many, and around the world. But it's like that frog in the water. it's happened so slowly, 12 people here, 20 people there, somebody's grandparents, someone's child, very, very slowly. People's reaction has been most interesting and sad, right? Because instead of bringing out the best and the most generous aspects of people, it's brought out people's hatreds, people's angers, people's tribalism. So it's quite interesting. I think it's a thing. I think if we look at pandemics and plagues, this happened before in Europe with the plagues. They started killing Jewish people, right? They blamed the Jews and they murdered all the Jews. They started the Crusades. They burned women at the stake and called them witches, right? It was this funny craziness that when you have a sudden onset catastrophe doesn't seem to happen. So I find it interesting. So yes, it is a disaster, but it's a disaster for our souls in addition for our bodies. Yeah.
That is such a poignant way to put it, and your observation about the difference in the way we handled Haiti versus this pandemic is so interesting. My next question tries to look at this from a public policy standpoint. Have you seen any obvious gaps in American policy from the perspective of gender based violence? For instance, our team at CVT detected a sharp rise in domestic violence during COVID-19, and we see very little action from the legislation. So, how do you think these gaps can be bridged using policy, and which areas, in your opinion, need more work?
I will start by saying I'm not really sure. I feel somewhat naive and a little bit uneducated about what's the best way to manage this from a policy point of view. I mean, I think that the preoccupation with this sort of universal threat and people either buying into the fact that we need to socially distance and wear masks and so forth versus people seeing it as a political issue and fighting against it. And then on top of that, people getting ill and all the management and stuff like that. I think that that has led to an inattention to other very important issues. And the inattention ranges from domestic violence to issues of crime. There's been a rise in crime, at least in the United States. Again, I don't know about other countries, but I suspect part of that is policing is different. And then, of course, the waters are very, very muddied by the sort of racial tragedies, the death of African American men in our country and women at the police hands. That sort of again muddied the waters in terms of policing and the tumult about that. But there's that. There's the issue of nutrition. There's the issue of shelter and homes and the risk of people being evicted from their homes. There's the whole job thing. So there's all these different things. And I think in all that mix, gender-based violence is the silent victim, right? It's sort of women are, and children are very much confined. They can't socially distance. They can't leave. Shelters are not necessarily as available because of the whole issue with COVID and not trying to bring people together in a environment where there's too many people that could potentially get sick from COVID. And I think as a result, it's not really being addressed. I would say it needs to be addressed by education, by being part of the talking points in news. It probably needs to be addressed by finding creative ways to have interventions, right? Because if you call and say, I'm being beaten, I think my life's at stake, you kind of need to have someone say, okay, here's what you have to do. So we need to set out guidelines for hospitals, for clinics, for hotlines about where are safe spaces in this world of pandemic.
Those are excellent points, and I completely agree with you. Research also suggests that the 1918 Spanish flu also saw a sharp rise in domestic violence, most of which is undocumented since it was 100 years ago. So, despite having advanced so much in the past 100 years, the shame that is associated with domestic violence still potentially exists, which is my guess for why so much of these cases still go unreported. So, is this a valid intuition to have? And can you share your thoughts on this?
That's a fascinating question. Thank you for bringing it up. I'm not a historian, and we're all learning together, I think, on this issue. The Spanish flu, the influenza from 100 years ago, 102 years ago, is most interesting, and from many aspects. And I think shame is definitely there, isn't it? There wasn't even a memorial to all those people who died in the Spanish influenza. So again, I think you have underneath this large amount of loss, you have the other secondary victims of this big pandemic from 100 years ago that totally are voiceless. It's really quite sad to me. I feel like in contrast, we have not been voiceless. One of the things that we've been looking at is the literature and the outpouring of documentation that's been going on during the COVID-19 pandemic. There is a huge amount of documentation for gender-based violence, for intimate partner violence, these crises. There's a whole sort of separate category of intimate partner violence or gender-based violence that's happening online. There's a lot of stuff that's going on, and it's being documented. There's hundreds of articles, both academic publications, news articles, blogs, websites. So I actually have a sense of optimism that, unlike the Spanish flu, which had zero technology, right, in terms of getting the word out, perhaps maybe somebody kept a diary someplace that's in an attic someplace, if you're lucky enough to find it. Here we have a different situation that we are going to get this information out.
Definitely. So we've come to the last question for this episode, for which I'd like to hand over the stage to you to tell us more about Strengthen Serenity, as well as the training that your team is currently providing with regard to violence in disaster settings.
Thank you very much. So Strengthen Serenity is the name of a very small group, which is based at Mass General Hospital, and was started a few years ago with some charity donations, some funding to look at the issue of outcomes for women and look at gender-based violence in the setting of societal structural violence. And it really started with an insight that many of the reproductive outcomes that we see, such as maternal mortality, cervical cancer, dying from cervical cancer, issues of malnutrition, and so forth, really are the end game of a lifelong experience with gender-based violence, a lifelong normative environment that allows women to be neglected, abused, not educated, not fed, not allowed to go to the doctor, and so forth. And as a result, you end up seeing it. As a physician, I see it as the end game, someone coming in and dying in childbirth, someone coming in and dying of cervical cancer, things that if you were able to have intervened months earlier, or in the case of cervical cancer, years earlier, it would have been a preventable death, And then, of course, there's a consequence to women dying young, which is their children are without parents. And as a sort of side comment, there's been several very compelling studies that have looked at the outcomes and survival of children in families where the mother has died. There's a big study out of Bangladesh that looked at survival of children who didn't have a mother compared to those who did have a mother. And it's extraordinary, the difference in survival. It didn't matter if you had a father or not. So there's huge stuff that's out of that. So with that as background, I developed this group called Strength and Serenity. Strength because women are so strong, and serenity because you have to stay calm. You have to stay calm and find meaning and enlightenment. So far that have been developed is, on the one hand, academic in terms of writing and publications and developing a large database of literature that is being put on a new website that just was formed, that is available to anyone who academically would like to look at a particular aspect of gender-based violence and use this bibliography. It's a huge bibliography now, to help them in their research. That's the one thing. And the other thing is training. And so we have started 2 years ago training of disaster responders in both screening and intervention for seeing on the field people who experience gender-based violence. And then the final thing is sort of ongoing development of research projects in a collaborative international way. And our current research project that we're working on is working with a group in Tanzania and looking at something called obstetrical violence or disrespect and abuse in childbirth, and developing a survey, a mixed methods, qualitative, quantitative survey of providers of maternity care to understand why women are abused by providers of maternity care when they're in labor, which is a big thing worldwide. So those are the things that currently Strength and Serenity is working on.
That sounds like a wonderful initiative. So that brings us to the end of this episode, and I wanted to thank you for agreeing to do this. I absolutely enjoyed speaking with you, and I think this is just the tip of the iceberg in terms of kickstarting these important conversations. I'm sure our viewers will take a lot out of this, and we hope to have you again soon.